Dolly Dastoor is no stranger to our organization. And in fact, it's a continuation of Dr. Dastoor's presentation in February 2021, when she introduced us to the comprehensive topic of what is Alzheimer's. And at that time, there was a great deal of concern as to how do we deal with people whom we encounter who are suffering from dementia and Alzheimer's disease. So welcome again, Dolly, and welcome Caitlin for managing all this so efficiently. Dr. Dolly Dastoor is a clinical psychologist well known in the psychiatric community for her prominent work in dementia and Alzheimer's disease. And she will share her knowledge and experience on an important health issue of how we manage difficult behaviors in dementia and Alzheimer's disease. She's an assistant professor in psychiatry at McGill and is the chair of the education committee of the McGill University Research Center for Studies in Aging at McGill. In 2001, she set up the program in dementia with psychiatric comorbidity at the Douglas Mental Health University Institute and served as co-director until retirement in 2013. Born in Mumbai, India, and obtaining a master's degree in psychology from the University of Bombay in 1964, Dr. Dastoor came to Montreal in 1973 after 10 years in Nigeria at the University of Ibadan, where she was a senior research fellow in psychiatry and project coordinator for the World Health Organization project in schizophrenia. While working as a clinical psychologist in the memory clinic of the Douglas Hospital, Dr. Dastoor specialized in the assessment of dementia, especially Alzheimer's. And in 1996, together with Dr. Martin Cole, she developed an assessment tool for the prognosis of this disease by studying models of cognitive decline with geriatric patients to obtain a prognosis and functional picture of dementia in patients. For her outstanding contributions to this field, she was awarded the C.A. Roberts Award for Clinical Leadership in 1990. Notably, while doing a full-time job, Dr. Dastoor completed a PhD in clinical psychology at Concordia University in 1998, the same year as two of her children graduated with doctorates. Her life is guided by helping people cope with emotional suffering, supporting the empowerment of women and gender equality, and making the Zoroastrian faith relevant to the community's youth in North America. She was a founding member and president of the Alzheimer's Society of Montreal from 1986 to 1991, and since May 2021 has been the president of the Montreal Council of Women. And I'm delighted to welcome Dolly to our session this morning, a real trailblazer in dementia care. Welcome, Dolly.
Thank you very much, Renata, for this wonderful resume of my life, which I'd almost forgotten. But that's good to have reminded. Okay, what I'm going to do today is, since you mentioned that I have been here in February or March or whatever, to refresh a little bit of what we did before so that you understand what the disease is, what is causing the difficult behaviors, and then we have to appreciate our own strengths and limitations. We have to accept them. We learn to take care of ourselves better, to look after our loved ones, and then to develop strategies to help ourselves and our loved ones. So that is the template which I'm going to do today. And I will start with a little bit of background of what we did last time. So to refresh your memory, to see, understand, and comprehend again what the disease is. So first of all, we always think of memory as being the most important thing, and it is, because that gives us the essence of our being. It connects us to our past and connects us and helps us to our future. Then what is memory? Memory is the dance of chemicals. You can't see memory, you can't see it in the brain, but it's the dance of chemicals and electrical activity in the brain. And there's just not one memory, there are different memory systems. There's an explicit memory, which is the declarative, which you consciously make an effort to remember something. You have to make an effort to remember an episode, and that declines with age. Then there is a semantic memory where you have remember words, images, overlearned material, and that does not decline with age. It is not dependent on anything. It is just our own self. It may be temporarily inaccessible, but it is not gone. And then you have implicit memory, which is non-declarative, which means that it's a procedural memory. You don't have to make any effort. It just is there. It's like your motor skills, like learning to drive, to make coffee in the morning, or to do your chores. Those are just automatic actions which just take place. And that is non-declarative. So you have two types of memories, explicit memory and implicit memory. And how do we form these things? These are connections in our brain cells. We have billions and billions of brain cells in our cells in our brain, and they form these connections, and each experience alters these connections. Okay, so those are the strengths. How often you do something, it makes the connection stronger and stronger. Okay, how do we store these memories? You have your sensory memory, what comes in through your senses, through hearing, to your vision, to your touch, and there is, you don't lose with age. And we wear our glasses, we wear our hearing aids, but that's about it. And then you have your primary memory, which is a short-term memory, which minimal loss with age, which you have your telephone numbers. You look up a telephone number, you phone, and now you don't even do that with your cell phones. It is just automatic, and you don't even remember those numbers anymore. And that's the working memory, and this needs to be rehearsed and repeated. If you want to remember something, you have to repeat it a couple of times to remember it, otherwise it just disappears. And then you have your secondary memory, which is a long-term memory. So you have a sensory memory, you have a primary memory, which is a short-term memory, and then you have a long-term memory, which does not decline with age. Once you have something in your brain, once you have absorbed in some material, it stays. And that is like a hourglass. What you see when you see the hourglass and the sand sinks, that's what happens to our memories. It sinks to the bottom, and as the lower down it goes, the stronger it becomes. So I'm just digressing a bit, if you have people who are suffering from dementia or memory losses, you will see that they tend to remember things of the past much more than what they happened yesterday or today. And that is because what you took in today, it doesn't stay too long. That's a short-term memory. But if you repeat that thing again and again and again, and repeat that day after day, it sinks in and it becomes into your long-term memory. Okay, so there's a relationship between this primary memory, the short-term memory, and the secondary memory is very interactive. It goes together. And recognition sometimes is better than recall. You can't recall things, but if you see something, yes, or there's a cueing. And cueing, you can recall things better when it's cued. A word is given to you, an object is given to you, see something, and then you recall it. So that's it. So the model is you have a working memory, then you have an immediate recall, and you have a delayed recall. And the working memory declines within milliseconds. And working memory and immediate memory together comes up with short-term memory. And that stays between 30 seconds to about several minutes. And then you have when it turns into your long-term memory, which goes into from 15 up to minutes, about 25 minutes, and much longer. So that is the model of the memory. When you say, I've lost my memory, it doesn't mean that you've lost everything. It's maybe one particular part of memory you have lost. Sometimes after a stroke, people forget the immediate things which they've learned, but they remember the past, or is vice versa. It depends which part of your brain is affected. So why do your memory decline with age? Aging is inevitable, but memory loss is not. It doesn't mean that just because you're 80 years old or 85 years old, your memory is not good. It happens even when you're younger. It happens with the damage of brain damage. You can lose your memory. Age has nothing to do with memory loss. It may become a little fader, become a little slower, but it does not mean that you lose your memory. And what are the areas in the brain vital to memory? Let me see. The hippocampus. This little part, this blue thing, is the hippocampus. Yeah, the memory resides there. So that is a very important part of your memory. This is essential for working memory. Then the frontal lobes, because what you're saying goes into your hippocampus and it's transferred to your front of your brain, which is your frontal lobes. The other part of your brain, which is important, is the amygdala, which is another section in your brain, which is associated with emotions of your memory. If you had a fear, you had an image and you have fear, that fear stays from your amygdala. That is important. And then you have the thalamus, which controls your attention, which is a little gland in the front, which and that gland, it gets activated when you want to pay attention to something. So when we were younger and when we had children and they would cry in the night, we would jump up and go because your brain was very active and you were on the alert. The thalamus was on the alert. But now, if somebody cries, if you have a grandchild staying there and somebody cries, you're not going to jump up and grow because your brain is not active at that time for the thalamus. So the activity in the hypothalamus and the frontal lobe slows with age. That's a truth. It slows, but it does not lose its function. Does not due to loss of connection, synapses between nerve cells. What happens is the synapses, the nerve cells are there and you have connections between the cells. And so these connections become lesser or becomes slower, I shouldn't say lesser, becomes slower. So the impulses don't go as fast as they used to go before. Before you could think something in an instant, and now it will take 10 instants to get something back because the connections are slower. It's not gone, it's slower. So here is the different parts. You have the frontal lobe over here, and you have your different areas, and the temporal lobe is quite important because here the memories first come in and you get it, then it converts into the frontal parts. Over there, okay. So how do we preserve the memory? Lifestyle, cognitive activities, positive attitude, and use of efficient strategies. Let's go. Exercise, lifestyle, exercise is important. We've talked of that before. All types of exercises, mental exercises, physical exercises, exercise at least 30 minutes a day, 3 times a week. With COVID, it was a bit difficult to go to gyms and things, but you could always walk and have walking exercise. Diet is important in your lifestyle, a pro-memory diet, low in saturated fat, high in fruits and vegetables. Vitamin B12 is important, folate. You don't get folate in food, you can get it in spinach, you get in citrus fruit, asparagus and beans, and that gives you iron, and iron is important for your functioning. Folic acid, vitamin E is important for your skin and your nails. You get it in the nuts, you get it in oils, you get it in protective. It protects your brain from aging. It's an antioxidant. Sleep. Sleep is also very necessary for memory functioning. We think that sleep is not, what's the use of sleeping? Oh, you sleep when you're very tired, but you sleep when your brain is tired too, because your brain rejuvenates when you are sleeping and it becomes more active. And sleep is very important. You can't stay without sleep. I was just reading the other day that you can go without food for at least 10 to 12 days. You can go without food, even a month up to, depending on how much your body fat is there. But you can't go without sleep for more than 36 hours. After that, your brain doesn't function very well. That is why you have tortures with sleep deprivation. And even when pilots and frontline staff or surgeons or residents, you can't go for more than 36 hours without sleep or their duties. They have to change. You can't function. And the other thing for your lifestyle important is stress. Everybody has stress, but how we manage stress is very important. The stress is controlled by a hormone in our body, in our brain, which is called cortisol, and that shrinks with stress. It is very close to the hippocampus where the memory is stored. And when you are more stressed, the hippocampus shrinks and the cortisol becomes more important, it generates more. And so it alters your memory process. The more stressed you are, the less you remember. So remember that when you are, try to control your stress as much as possible, and we'll see how we can control stress. And the other start of the lifestyle is the social and leisure activities. Groups like this, conferences like this, help you get together and help you generate your leisure activities and social activities. And that is an important part of our living. Other part of lifestyle is control your body weight, monitor your diabetes at a good glycemic control, controlling your hypertension, taking your medications, and controlling your osteoporosis. Because all this help you maintain your good body image, good body functioning. Okay, osteoporosis is also important because with aches and pains and you can't have your hip problem, you can't walk, your lifestyle changes. Your lifestyle is not as good as you would like it to be. Other aspects of preserving memory is cognitive activities. Now, if you keep your body in shape, you have to keep your brain in shape as well. So you have to learn new activities a year, not passive, not just sitting and watching Netflix or just watching things, but by actually doing things with your brain. Use of how do you also preserve memory? By using efficient strategies like internal memory aids, which you have writing notes or organizing things in your brain, making connections between different aspects. Sometimes you cannot remember a name. You see somebody, you don't remember the name, but as the person goes away, you remember it because you try to associate that person with an event or with you maybe met the person from school or you know them from another context. You try to remember that and you put meaningful connections together. And organize the information you want to remember. So external aids are there. You have your agendas, you have your post-its, you have your filing systems, you write things down when you're going shopping because you can't remember everything. So external memory aids and your internal memory aids. So those also help you to remember your better instead of taxing your time all the time with your memory. But I don't think we should pay too much importance or too much become too dependent on external memories. We should try to help our internal memory to work as fast as or much as possible. So what are the 10 warning signs of decreased memory? It's memory loss that affects day-to-day functioning. From one day to the next, you keep forgetting. You don't know how to do things which you were doing all the time. Then you have difficulty performing familiar tasks. Things which you're doing like writing your checkbook or doing your favorite recipes. You forget, you have to look it up. Then you have problems with language. Sometimes you cannot get the most familiar word out. You have the difficulty. And now those are the things, if you keep remembering these, these are the things when people start beginning to have memory problems, show early signs of dementia, those affect the person. When you feel that you cannot speak very well, you cannot express very well, the problems start coming. You become disoriented to time and place. You forget, you have to look up the calendar more often as to what date today is. Because it's natural that when we are retired, every day seems the same thing, especially with COVID. Every day is the same, it's the same routine. So we have to make an effort to remember the date and time. That's understandable. But when there is no COVID and then you have the difficulty, that's the problem. When you have poor decreased judgment, you feel when it is a very cold day, you go out without wearing a coat or being properly dressed. Or when it is very hot, you put on things. You go to somebody's apartment and it's boiling hot because all the heaters are on. When I used to do home visits, I used to feel that, and that's poor or decreased judgment. They don't feel it. They don't make a good problems with abstract thinking. When we have to plan our route, we have to go somewhere, or we have to write a check or make a payment. We don't have to sit down and need to have the item in front of you. You make the thinking in your mind. But with people beginning to have memory problems, you need to have the object in front of you. You can't think in the abstract. you try to misplace things. I think that's very common. We all misplace things, but we find them and we try to remember them. But people beginning to have memory problems, they put it somewhere very safe to think that they will find it. This is the place where I should put it, but they cannot find it again. And they say that we spend, and this is not a joke, we spend at least 1 month a year cumulatively finding things which we have misplaced. And sometimes we think that we are looking for something which is red in color, but it may be completely different color, but that you're stuck in your brain with that particular color. So misplacing things is very common, and it takes up a lot of time to find things. Then there's changes in mood or behavior with people who were calm and even keeled, and the behavior was very normal, suddenly start behaving in an irritable manner. They get angry very fast. You start using abusive language. Their mood changes. They become depressed. So there's a changes in mood or behavior. Then there's changes in personality, which the two of these go together. Then there's a loss of initiative. People don't have the initiative to do something. When you say, can we go to a movie, or can we do this, or can we do that? No, I don't feel like it today. You go ahead, I'm okay, So there's a loss of initiative to do anything. Okay, so these are the 10 warning signs. They all don't come together. This is not in any particular order, but memory is usually the first thing to be affected. So these are what you should be looking out for, either in yourself or in the person you're looking after, because they will be the starting points of behavior problems. So what is dementia? Dementia is a syndrome or a group of symptoms resulting from a structural loss or death of nerve cells in the brain. It is not necessarily due to aging itself. Dementia can happen to people who are young as well, as young as 45 or even younger sometimes. It has a very insidious onset. It starts very gradually. You don't know, you don't have a starting point to say, oh, today I had a fever, or today I had this, and I began to have dementia. It's not that. And it's a very progressive decline. It's not like from one day to the next. It starts with smaller things. You forget a few things. Then after a couple of months, it's more. And it's gradual decline. And it slowly destroys your cognitive, your thinking processes. It destroys your functioning. And then you have behavioral abilities, behavioral problems start coming up in dementia. Who has dementia? It's less than 10% of people who experience lapses of memory develop dementia. Every time or everybody forgets something or has little memory problems does not mean that you're going to have dementia. It's only 10% of the people will develop dementia full blown. But even before these symptoms of memory or language or behavior start, there are plaques and tangles are already being formed in the brain, which are affecting the learning and memory part and thinking and planning. So the first things to be affected, the first thing to be noticed in your behavior, also in the behavior of the person you're looking after, is learning. They cannot learn new things as fast as before. They cannot remember things as fast as before. And that affects their thinking processes, and that affects your planning. They cannot plan out what they're going to do for the whole day, or the things which they're going to plan for a outing, or they're going to have a vacation, and how to plan out different things. Those things get affected. And that's when you start noticing this person is not behaving as they should be behaving. So what are the symptoms in dementia? Memory impairment, I said, is the most important thing. And the other cognitive impairments, which are equally important, but not as prominent as the memory to start with, is language functions. You cannot express what you want to express. Your words don't come out as much as you want. Your writing gets affected. Your reading gets affected because you can't follow the lines properly. It keeps jumping. And your executive functions are affected. Apraxia and agnosia. Apraxia is the ability to do things with your hands, like you button your dress, you tie your shoelaces, for men to shave and to comb your hair. Those apraxia, those functions you forget how to do it. I had a patient with whom I had gone, I used to do home visits, and we went to the sink. She had to wash her hands. She looked at the sink and she didn't know what to do. She didn't know how to open the tap. So that was apraxia. You don't know what the function of these things are. And agnosia is the same thing. You don't know the functions of the things. You lose that. And that becomes very frustrating to the person. And then there's a functional loss in ADL also. You cannot function as well used to function before. Sometimes you get urinary tract, you become incontinent of both feces and urine. And so as the dementia progresses, your functional loss becomes more and more apparent. But in all this, what happens is this clear consciousness. The person doesn't look confused or doesn't have an air which is, they're not conscious. They're all the time conscious. And there's no depression in the beginning. Absolutely no depression. Till the person starts beginning to know that something is wrong with them. Prevalence, the dementia is increasing like leaps and bounds. In year 2000, there were only 20 million people globally. And in 2015, there is 46.8 million people. Can you imagine in 15 years, how much has this increased? Double, triple? And by 2030, they think we're going to have projection is 74.7 million people. There's a lot of people, and that will be a lot of behavior problems. There's a lot to look after. Now, dementia is not just Alzheimer's. There are different types of dementias. There are about 60 different dementia types. But the most common is Alzheimer's type. About 64% is Alzheimer's. The rest is vascular dementia, where your blood supply is not enough to the brain. This frontotemporal dementia, where the behavior problem is much more prominent than memory problems. Then there's alcoholic dementia, which you don't see that much because alcohol consumption is much controlled now. And there's Lewy body dementia, where the small cells on the top of your brain get affected. And the Lewy body is more like people have more hallucinations. They have more delusions. They see little things on the ground and they try to put their steps over it because they cannot walk. They feel that they're going to fall. And the most common feature of all these dementias is memory, in different aspects of memory. But memory is most important. Again, I said the most common Alzheimer's dementia, which is 64%. And the World Alzheimer Report, which just came out this month, last month, September 21st, stated that 46.8 million globally, that is about 9.9 million new cases every year. Can you imagine? And 32% of people, someone knows someone with Alzheimer's disease. I'm sure all of you know people with dementia or Alzheimer's disease. And 21% have someone with the dementia, Alzheimer's disease in their own family. I think you can all attest to that. And women account for over 2/3 of those over 65 with the disease. Women seem to be affected much more because we live longer for one, and we seem to have more prone to it. And most caregivers are also women. So caregiving and how to manage caregiving and how to see behavior problems is very much more important for us because we are more involved with caregiving. The annual societal and economic cost globally is about, in US dollars, in 2010 was 6.4 billion. And in 2021, it's shot up to 1 trillion in the United States. It's tremendous. It's too much. The rising cost of dementia will pose serious challenges to healthcare and social care systems around the world. We saw that in the pandemic when people in the nursing homes were not being taken care of. And this became apparent. Nobody knew what was happening there till people started dying of there because lack of care. The monetary costs in dementia estimates in Canada, in 2016, it was 10.4 billion. In 2031, it's going to jump up to 16.6 billion. And as healthcare system, public, plus the caregiver costs, the private caregiver costs. The family caregivers and unpaid hours of care in 2011 Volunteers, family members gave 19.2 million hours. 2031 will be 38.4 million hours. And if this includes the income lost by caregivers, it's about $11 billion. So that's a very inexpensive disease to care for. And who are the caregivers? The caregivers provided daily care. Spouses are the most important, about 46%. And the average age of the spouse is 74 years. So the older persons are looking after older persons. So and most of those people who are caregivers are also employed. 15% are also employed. The other big group of people is the adult child. This 44% of the caregivers are adult children, whose average age is also 54 years old. So the adult child is also older. They have their own health problems. Out of the elder child, 71% are daughters, again, women who look after them. 71% live in the same household. 60% of these daughters or the sons are also employed. So they have to juggle between caregiving and their own lifestyles or their own working lives. Sometimes friends and neighbors also help, but that's a small percentage. You have about 9% of people who help with that. So let us now briefly review the stages of Alzheimer's disease. As I said, it's a progressive thing. It doesn't start from one day to the next. You have the mild disease, mild stage, which lasts for about 2 to 10 years sometimes. So it's not just an overnight thing. And you start becoming forgetful recent events. You have difficulty with complex tasks. You become suspicious a little bit. You say, who's this? If somebody's looking at me. Somebody's stealing things from me. They become a bit suspicious. But the physical examination is normal. And that is why when you take them to the physician, you can notice something was wrong. But the physician will say, no, the person is quite all right. It's just aging. Don't worry about it. It'll go away. They're not very attuned to picking up little nuances of the problems with the elderly people in the early stages. When then it starts beginning to be into a moderate stage, people can pick up difficulties. The difficulties in cooking. It will cook and people come for their children come for dinners on Sundays or whatever. They cook the same thing every Sunday, or they are not handling money. They're not bringing back right change if they go to shopping. So it's easier to cheat people with moderate dementia. They're unable to maintain their homes. If you go to a home of a person who has moderate dementia, you see it's not very tidy. It's unkempt. You have paper all over the place, or you have dust, or it's not, the dishes are there in the sink. They're not cleaned properly. So the maintenance of the house is not there. Sometimes we also don't have proper maintenance, but we try to clean it up at least once a week, Then there's difficulty in managing medications. It happens that even with the pill box, they don't remember whether they've taken the medication or they've not taken the medication. Or sometimes they take the medication twice. And so it's difficult to manage medication. If they're living alone, the family members keep phoning them every day. Have you taken the thing? They're phoning them in the morning, in the afternoon, in the evening. If they're 3 times they have the medication, to keep reminding them to do it. And that will have complications, either if they don't take medications or if they take too much, if they take double the dose. So that's another problem. Then the little recall for recent events. Sometimes when people are already placed or they are living alone and say, oh no, nobody came to visit me. And the children may be coming every day or every second day, or they may be phoning them, but they don't remember them. So sometimes we ask our patients or us to keep a log and to show to them that, and when you come to visit them, to write your name and the time you came so that they can remember. So that's one of the other difficult problems, that they cannot remember, they cannot recall what's happening. And then they start, at the moderate state, they start beginning to have agitation and aggression. Because they cannot remember things, they cannot remember where they put things, they start becoming suspicious, they become agitated. And I think it's normal between you and me. If we cannot remember where we put things, we start looking all over the place, and you become agitated, and then you become aggression also. Aggressive, not aggression. Then as the moderate stage goes into a more severe stage, which may last about 1 to 2 years, they have difficulty dressing. They put their hands and sleeves in the wrong hands, or they cannot comb their hair well. They cannot shave. Sometimes they shave only one side of the face. The men, they have difficulty swallowing. They become choked because the swallowing reflex doesn't work properly. So you have to give them softer food, mashed food, which doesn't taste very good. They start beginning to have fecal incontinence. They start beginning to have gait disturbances. They cannot walk very well. They have a little shuffling gait. It depends which part of your brain is affected, but they cannot walk. It's not only just arthritis or just because the hip, but it's the ability to walk. The actual act of walking is not there. Then they start beginning to have hallucinations and delusions. They see things, they see objects, they see people, or they see animals. Mostly the elderly in the dementia, they see little animals around, Sometimes you see a little mouse in your house, but that is not what is a hallucination is. They see things, imagine things. Even the shadow gives them an impression that it's something else, So hallucinations and delusions, that is difficult to manage for behaviors. There's poor recognition of family. Because they can remember the older things much better, they can remember their children or their spouses maybe, but their grandchildren is not remembered very well. They cannot remember their names or their faces. But sometimes you have, this is another very common thing, when you have a second wife or a second husband, you don't remember the name of that person as much as you remember the name of the first wife. So that's the poor recognition. Little recall of past life, restricted vocabulary. The words don't come out as much as they used to before. And there's neurological abnormalities. Little reflexes which we had as we were younger, as babies, return back, especially the grasp reflex. The baby, when you give them a finger, they clasp onto your finger and hold on to it. And as in dementia, you will see that reflex is coming back. And neurological abnormalities are there. What are the risk factors? Age. It affects people as you get older. Genetic factors and environment. Those are the three main risk factors for dementia or Alzheimer's. Age. People at the age of 30, we lose only about 4 to 8% of brain cells every 10 years. As you grow older, at age 60, you lose about 15% of brain cells. As you grow older still, at 80, you lose 60% of the brain cells. After the age of 100, 50% of the brain cells are lost. And this can't be true, it must be more than that. At age 150, 100% of brain cells are lost. So the more the brain cells are lost, the more prominent the impairments comes up. So by the time it is apparent that there is a problem, 60 to 80% of brain cells are lost. So there's nothing much left in the brain to work with pharmacologically. What are the genetic factors? Our chromosomes are affected. When chromosome 1 is affected, 1% of less than 4% chance of familial. And there are 400 families worldwide which has chromosome 14 affected. And the age of onset is early. When you have somebody early in their life developing dementia, it is usually between the ages of 28 to 50, and that is because there's a damage on chromosome 15. That's the most important chromosome. Then there's chromosome 19, which is ApoE, common form of AD. The most common form, which everybody has, is ApoE. Not everybody, those who have dementia have a damage on the chromosome 19. And that is between 50 to 60% of people with dementia have ApoE. That's a particular brain damage. And 21, there's less than 1%. Where this is with people, with children born with Down syndrome, and if they live up to the age of 45 to 65, almost everybody will have dementia. Whilst they're younger in the Down syndrome, it's not so apparent because now there's lots of new techniques and new interventions taking place, they can manage. But that is where we all have 2 copies of our genes, whereas in Down syndrome, they have 3 copies, and that causes dementia. Okay, the environment is a risk factor, is a big environment. Education. Lower levels of education causes low socioeconomic status and gives poor diet. It does not mean that just because you don't have education, you will get dementia. It means that with poor education is associated with the low socioeconomic status, and you don't have enough money, then it gives you, you take a poor diet and you try to take diet with too much carbohydrates and you don't eat proper food. You don't eat enough proteins. Then hormones are another risk factors. Head trauma, those who have ApoE gene factor, those who are with boxers, who have head trauma, who have accidents, injury to the head, that causes more ApoE4 genes and you have more head trauma. Hypertension, with high blood pressure, your blood pressure increases and your blood supply in your brain is not adequate. So hypertension is another risk factor. People always tell you to keep your blood pressure under control. When you keep that under control, the chances of having dementia or memory loss is much less. In Down syndrome, we talked about that. Another part of the protective factors, higher education. Higher education gives you a chance to have better coping strategies. It gives you a chance to look into different strategies, to how to manage your little losses of behavior or little losses of memory which you have. You take estrogen, it stimulates the release of natural hormones, which helps you. Exercise is a protective factor. It gives you the blood circulation is enough. Anti-inflammatory or hypertensive drugs are important to keep you. Antioxidants, which helps you, controls your cells. Vitamin E, B, and C are important, are good components to have as antioxidants in your diet. Red wine, which is good, not white wine. The mold, because of the skin, acts as an antioxidant. And the antioxidants help maintain your tissue health. And why? Because the red wine, when it's made, they crush the wine with the skin. And the antioxidants are in the skin of the red wine, or the red grapes. Cholesterol-lowering drugs help you, protect you. Good diet, good social support and network, which gives you, stimulates your brain, and spirituality. In order to have some meaning in life, the essence of life, and that gives you, it makes it meaning. And how can I say, I can't explain it better than it gives you meaning and a purpose for your life to be living, spirituality. Are there any treatments at the moment? The first one was in 1997. The last one was in 2001. And they are not cures. None of these cure you. They just slow it down. And this year, they had a new drug which was up there, but they had to withdraw it because they were too quick in approving it, and which was not very effective, or which was not very safe. Now, we think of dementia as cognitive loss. We think of dementia as having memory loss, which is true. But at the same time, you also have non-cognitive, psychiatric, and behavior disturbances. 90% of the dementia people show psychiatric and behavior disturbances. And what are those? Agitation. You become agitated. You start seeing them wandering in the house or getting outside the door and going out and getting lost sometimes. You see them vocalization, saying something which doesn't make too much sense, and you try to understand what they're saying. Then they become aggressive. There's aggression. Now, all these don't happen at the same time in everybody. At different times, different things appear, and it goes in stages, and you should see, and there's aggressiveness. So these things occur in about 43 to 93% of cases. It's troublesome. So what and how do you manage these symptoms? You can have physically non-aggressive behavior problems, which includes pacing up and down, inappropriate dressing and undressing, trying to get into different rooms, handling things inappropriately, general restlessness, and repetitive meaning behavior. Then you have physically aggressive behavior. This is physically non-aggressive, which doesn't really bother anybody else. It's annoying, but it's not physically harmful to anybody. Then you have physically aggressive behavior where the patient or person will start hitting, will start kicking, will start pushing things, will start scratching, tearing things down, grabbing people, spitting on people. And this you see much more in nursing homes where, and it's very difficult for the staff. We have to train the staff how to manage this, how to manage somebody hitting to you, kicking to you, how to hold the hand, because it's dangerous to the staff. Then you have physically, verbally non-aggressive behavior, where they start complaining, they keep talking, they have constant requests for attention. Everything is no, 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 you want to do this, no, there's negativism. Then there's a lot of screaming. We had patients who would scream non-stop from morning to night, and all sorts of things we didn't know how to stop it anymore, repetitious sentences or questions, asking the same thing again and again. And then relevant and irrelevant interruptions. You're talking to something and they interrupt you. But all this is still non-aggressive. It's annoying. All these behaviors are annoying, but they're not aggressive. But when you have screaming and cursing and temper outbursts and making strange noises, and they keep tapping on the geriatric tables, those are verbally aggressive behaviors, and they make curse you. And you should not, when you see that should not be taken very personally. That's the deceased speaking. That's not them speaking. So what is the helpful strategies for these common behavioral problems? One is restlessness is one of the behaviors. And how do you manage this restlessness? You have to try to distract them. You calm them with music or touch. And I can't see my own slides because your pictures are in the middle. Okay. And pacing is a form of exercise. If they're pacing and it's not affecting anybody, there's a space there in the house or in the corridors, in the hospital or in the nursing home, and they're walking up and down, they'll get tired and then they'll sit down and they'll rest. So that's okay. Let them do that because that's a form of an exercise. But if they're restless and they're hitting out people, that's another story. Then you have repeated behavior actions. If behavior does not bother, do not try to distract them with simple activities and change the subject and stay calm. When you keep correcting them and you say, no, that's not true. This is not how it is. This is it. That will not work. Correction does not work to people. They become more aggressive. So change the subject completely. Do something else and stay calm. If you get excited, if you get annoyed, that will reflect on the person and they will get very agitated and anxious as well. And sometimes people become very suspicious. As I said, they become paranoid. So you have to provide comfort and do not argue or try to reason. Do not take accusations personally. They're not accusing you personally because they said, oh, no, you only stole it. They accuse the nursing staff or they accuse the daughter who's in the house, who's looking after them. It's usually the person who's closest to them, who's looking after them. They accuse them more than somebody who's not there. And they will complain about that person to the other daughter or the other son or other relative who comes up that she stole it, and I can't find it. And it was there. So where is it gone now? She must have taken it. So that type of a suspicious behavior is there. But usually they have hidden it themselves. We find it, we turn the bedroom upside down, and sometimes we find it under the mattress or under the pillow or up on the top of the closet. They've hidden it somewhere safe, thinking that they will find it, but they cannot find it themselves. They have forgotten it. So people become suspicious. Do not take that accusation personally. That's very important, because it can become very annoying if they keep accusing you all the time. Repeated actions also, just try to distract them. What used to happen is that when I used to work at the Douglas Hospital, all the staff obviously went home at 4 o'clock. So they all went home and the front door. And so most of the ladies who were there would also want to go out with them. And that was a behavior, because they said that, oh, my children are waiting for me. They've come home. The school bus will be coming. I have to pick them up now, you know. So they live in the past and they want to do the same thing. So what can we do? We can't say, no, nobody's coming there. There's no children there. That doesn't work, you know, because in their mind, they're living in the reality, which is that they're 20 years ago, you know. So what we had to do, we had to change the whole system. The staff will not go out from the front door. They have to go from the back door. So then they would not know where they're going from. So the door was never open. So that was another tactic. So you have to think outside the box of how to be able to change their behaviors. So the best practices in all this behavior management is a focused, person-centered care. You have to change the environment, has to be supportive, and pharmacology. Pharmacology means medication. So medication does not work on all sorts of behaviors. You can't stop wandering behavior. You can't stop some behaviors. Some you can. But then what happens is that you try to give them calming behaviors, give common medication. So they become like sleeping all the time. And you don't want that either. You want them to be a bit active. So the behavior disturbances can also be primary behavior disturbances. For example, a sleep problem. Sundowning, that means they become more agitated when there's no light, and when the sun is down at sunset time in the night time, that's called sundowning. And that's a primary behavior disturbances. Then you have hoarding. They tend to hoard things. You find sometimes in the room little pieces of paper or little different things. Sometimes they pick up from other patients' rooms, or they pick up from somewhere else and put it in their drawer. And these are this hoarding behavior. Some people, even normal people, have hoarding behavior. Then you have restlessness. You become very restless, and physical aggression. Now, those are primary behavioral disturbances. The secondary behavioral disturbances are due to medical conditions. They may have a pain. There may be an environmental factor that may be too hot, it may be too cold, and they cannot express themselves, and it's too hot to remove some clothes. Then there's fecal impaction. They may be constipated for a few days and you don't know about it. And the more constipated you are, the more toxicity develops in the body. Then sometimes they have an abscessed tooth and you don't know that because they cannot express themselves what's wrong. If they have an abscessed tooth, they cannot express, and there's a pain, and they become restless and they become agitated because of the pain, you know. And you don't know till you suddenly find out that there is a tooth problem. Then there may be a small fracture, maybe a mild fracture. Sometimes even their bones become so fragile as they get older that even a slight turn can fracture their ribs. And there's nothing you can do for some fractures, you know, but those fractures are painful. So fractures, abscessed tooth, fecal impaction, constipation, or congestive heart failure, that also they become breathless. They cannot breathe very well. Hypoglycemia, too much sugar, too little sugar, which gives them chills, or their breathing is not good. They feel hungry all the time. So those are the secondary behavior problems which are due to a reason. So what sort of interventions can we do with people with behavior problems? We can do drug therapies, or you can do non-drug therapies. As I said, drug therapies do not work with all sorts of behavior problems. So non-drug therapies are our first choice. Music therapy. Music therapy helps because it soothes and calms the person, but the music should be also appropriate to the age of the person. We used to have staff who would put rock and roll music while the people were having their dinners and the lunch. And the people will get more excited and more agitated with that music. So we had to tell the staff, please change your music. Art therapy is also good because gives them a chance to express themselves. It gives them the chance to pick up this color or that color or draw this. Some very simple, you don't expect them to draw Picasso-like things, but something simple, even to follow the dots on the lines, and that's good enough. Reality orientation, but trying to bring them back to the reality. Used to have boards on the walls where we have the dates, then change the date every day, change the day every day, the month, is it raining today or whatever. So that gives them, tries to ground them and bring them back to what is happening outside, because they cannot imagine what is the date today. Reminiscence therapy is good because we would have a group together and show them old pictures or show them old movies, which were there, like maybe Charlie Chaplin movies or whatever movies, which they would know in their time frame, you know. So reminiscence, and maybe even pictures of their own family, of themselves, which they can relate to, and they can relate to what's happening to them, you know. Then movement therapy is good because movement is very soothing. We all like to sit on a rocking chair and rock ourselves, but that gives you a soothing feeling, because when the child is in the womb and there's a movement in the womb, and that is, movement therapy helps. I used to have a rocking chair in my office, you know, and some people used to come and sit there and just sit and rock. That's all, nothing, no talking. Or they would come and want to hold my hand, and I would just let them hold my hand, because touch is important. As I said, touch therapy. Nowadays, we don't touch people. It's supposed to be a taboo to touch people unnecessarily. But touch is very important for feeling grounded. People like to feel touched. And exercise, simple exercise. If the person is becoming very agitated, or you try to take them out, walk with them in the fresh air. In the Douglas Hospital, we had a large grounds, so they used to be able to walk a lot, you know, and we had to do that. So all these things you should try out first before giving them medication. And at the same time, to do some cognitive activities with them, simple puzzles, or simple recognition of objects, or sorting out things, putting macaroni of different colors in different places, or different tokens, so that they think about their thinking process is activated. Wandering, there's some more helpful strategies for common behaviors. Wandering, reassure the person and distract. That's very important. Put reminders out of sight. Sometimes people, when you see the hats and the shoes and the umbrella, they want to pick them up and go out. So you have to be careful to put them away, so that you should not leave cues for them to follow. And another important thing is to inform your neighbors that my so-and-so has got, if you see them walking around the road, or there, please bring them back, so that people are aware and they think about it, you know. Very often they don't want to inform people. They don't want to say, oh my, no, that's public. They should not know what's happening to my family, you know. But it's good for people to know and be aware of it, to help you. This is to help people. When they're aggressive, you don't become aggressive. You don't become more agitated. Be calm and reassuring, and give them space to cool down. If they're aggressive, you move away. They won't move away, but you move away, so that they have a little space and they can vent and rant and rave, and then they'll forget. And again, as I said, distract, and then look for an immediate cause. You can see, is it too hot for them? Are they wet? Does the diaper need changing? Do they need to go to the bathroom? Or are they hungry? There might be an immediate cause. The aggression or all these behaviors don't come out of the blue. There has to be a reason for them to behave the way they are behaving. Okay. Okay. Other very important thing is communications. The people with dementia in different stages of dementia has lost their ability to communicate. As we said, the words don't come out very well. They cannot write very well. So the ability to express themselves is lost. And so we, as caregivers, have to try to figure out what they think, what you think they want to say, and try to reassure them. Why do we use words? The words, we use them verbally, we use them, Sometimes we use expressions or communication can be, no, the communication can be verbal through words. The communication can be non-verbal through body language. And it can be paraverbal by a tone, by a pacing, by a volume of our voice. The tone gives you a lot of impression. The more your tone is angry tone, or your volume of your voice is loud, that gives you a different meaning to your whole conversation and communication. So everything should be calmer. You have to have people looking after them who can be calm, and you can adapt. In dementia, communication is affected. You cannot communicate very well, and this can cause misunderstanding and mutual frustration. And as the disease progresses, communication becomes increasingly challenging. In the early stages, the people can understand, but in the middle and the late stages, understanding is not there. Verbal understanding is not there. And the caregiver needs to find ways to communicate more effectively. Sometimes you communicate only with action. By saying you want to eat, you have to use some action for food, So if you said you want to eat food, they will not understand what you're talking about. So you have to do some actions. So the loss of verbal communications, this is repeating again, but it's important. The quality of the life of people with dementia is largely dependent on their communication with others. How the other person reacts to their behavior, how the other person understands their behavior, helps them to focus and helps them to calm down. Maintaining a relationship can be complex and challenging when verbal communication is lost. So verbal communication is very important. And all this, you should remember, also depends on your relationship before the dementia occurred. If you had a very good relationship with that person, if you had a very loving relationship with the person, you'll be able to understand and behave in a very different way than if you always had a very frustrating relationship. You had a very antagonistic relationship with that person. You will not be able to give a very good care. So relationship previous to that is important. Was it the common problems of communication as difficulty finding a word? You can't find the right word at the right time. Creating new words, or repeating the word or a phrase again and again and again. And sometimes you say, but you just said that 10 times. But that's not their problem. They just keep repeating. They don't know they've said it 10 times. Difficulty organizing words into logical sentences. Sometimes they may say one word, and then there's some mumble jumble, and then another word comes out. So there's no coherent sentence coming out. Sometimes they use cursing or using offensive language. Your mother or your father, whom you know is a very calm, peaceful person, never said a bad word, comes out with cursing language, And you say, where the hell does this come from? I never heard her say this before in my life. Where is this? So those sort of things come out. And these tend to revert back to their first language. If you had learned, in my case, I learned Gujarati when I grew up, then it was English and then French. Now the French is going out, the English, and then I'd go back to my original language. So that's another problem. You tend to revert back to your original language. Okay, so the challenge, there's a communication challenge at each stage of the disease. In the early stage, the person is, because they cannot understand very well your facial expression, the difficulty understanding humor and jokes. They don't pick up that joke. Sometimes you need to repeat it more times. We want to say, repeat it again and again for them to understand. And they lose the train of thought. They start with one part of the sentence and they trail off to something else. When you come to the middle stages, the communication becomes much more difficult. There's a trouble understanding everyday conversation. In the early stages, they can understand conversation. It takes a little longer. You may have to repeat it again or use a little simple language, but you can communicate. But in the middle stages, communication becomes difficult. They ask the speaker, can you please repeat again? What did you say? I don't understand. And the difficulty reading and understanding. They read the newspaper, they have the newspaper in front of them, and they keep reading the same thing again and again and again. And it's just, when you could, sometimes you say that they've not turned the page. They say this is on the same page. And because they've not read, They're just looking at the newspaper. They cannot read or cannot comprehend what they are reading. That's frustrating. Frustrating to you to watch and frustrating for them as well. In the middle stage, they're not able to interpret facial expressions. You may be smiling and laughing or be angry, but they don't understand what is happening to your face, you know. You may be able to wink at them or nod. There's no communication over there. Then they also have difficulty finishing a sentence. I said they may start a sentence and speak in some vague and rambling sentences, and they cannot finish it off. So it's up to you to sort of put yourself in that person's place and try to understand what they're trying to say. What maybe they may be thinking of, and that we have to try to finish the sentence for them. And in the late stages, they completely lose their capacity for recognizable speech. And sometimes what happens is a phrase or a sentence may come out, but that's occasionally. And then you feel, he's improving or she's improving, but that's not it. It's just the brain sometimes becomes activated and they can say a sentence, but that's very rare. Non-communication at this stage, late stage, becomes increasingly important. So touching or doing things and stroking is very, very necessary at this stage. You want to take them for a bath, or they say, when you can just say, stand there and say, come on, we are going for a bath. There's no effect because they cannot understand what the hell you're talking about. You know? So if you take them up, you turn the water on, you take them there, and you say, now we're going to take your clothes out. Demonstrate and do actions with them, but in the later stages, because there's no verbal communication. Non-verbal communication becomes very important. Unable to understand the meaning, most meaning of the words, I've said that. They lose the capacity for recognizable speech through words or phrases and may occasionally be uttered. Language does not make sense to others and become total. And in some cases, as the disease progresses, it depends which part of the brain is more affected. Sometimes they become totally mute, no communication at all. Okay, so how do you communicate if there's no verbal communication? Most important is touch, holding hands, massage gently the hands and legs and feet. And touch is important because that gives you communication with another person. Smell of a favorite perfume, a flower, or food may bring back happy memories. That's another way of communicating. That's why we used to have, even with people who were quite demented, our kitchen was there, and we sometimes would bake a cake or bake a pie or something, so that the aroma from the food, aroma from that would revive some memories, and they may become a bit more active and alert at those times. They bring back some happy memories. They may not express that memories, but the memory is there. Vision is also important way of communicating. Videos of scenes of nature and soft calming sounds may be relaxing. We used to tell our families that if there was an event in the family, make a video of it and bring it for a wedding or even a party or a birthday party. Bring that and put it in, we would show it to the patient so that they can see something's happening, because vision is there much longer than verbal communication. You can see things, hear things better. Yes, vision, scenes of nature and hearing can be comforting, even if the words are not understood. You can speak. Sometimes our patients, families would say, but what's the use of my coming? She doesn't know who I am. She doesn't understand. She does not talk to me. She does not understand all that. But the very touch, your touch, means much more to that person than my touch, because that touch is more familiar. And touch can be more comforting than words. If you just hold somebody's hand, they will feel much more comfortable than to say, oh, how are you? I really miss you. That doesn't make any sense. I mean, it makes sense, but they don't understand what you're saying. So the touch is much more important. And the tone and the rhythm of your voice may be more soothing, giving a feeling of comfort and safety. When people are very agitated, we used to find that just by holding their hand and stroking them and say, okay, Okay, that's okay. It's okay. I'm here with you. Don't worry. Just a simple voice and sound soothes people. But now you've done all this for the caregiver or the person you're looking after, but you have to look after yourself. Unless you are well taken to give proper care. So there has to be strategies for the caregivers themselves, because with the progression of the disease, a person's perceptions can become confused, and we can't argue with them because it is their reality. We have to accept the reality and meet them where they are. So avoid contradicting them or convincing them that what they're saying is untrue. No, 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 that's not correct. This is the right thing. Don't think of that. Don't worry, nobody's taking your stuff away. That's not going to convince them. Try to bring them to your reality will cause more frustration and make things worse. Try to connect with them and do not correct them. Correcting them is the worst thing you could possibly do, because they will become more angry that you're not believing them, you're not agreeing with them. They'll be more aggressive. So connect with them. So yeah, that may be possible. Yes, we'll find where you lost it. So you have to connect with the reality. As I said, the paranoia also becomes more prominent as it progresses. They say the food is being poisoned, things are being stolen, somebody's spying on them, somebody's trying to hurt them. Those are the common symptoms which people come up with. They may not say it in so many words, but it's there. And these are the results of the disease. And that's not willful or intentional, and you should not take it personally. The caregiver should not take it personally. Do not argue to convince them that the perception is not real. It is their reality. As a caregiver, it is normal to feel a variety of emotions yourself throughout all the stages of the disease. You may feel angry with them, you may feel upset, you may feel sad, you may feel guilty. It is important to acknowledge your feelings and care for yourself and seek practical help and emotional support for yourself so that you can help the person better. Again, very quickly, who are the caregivers? The informal caregivers are the family members and friends. And there are formal caregivers who are paid people. And who do they care for and who do they provide care? The scope of the problem and what do they need to know to protect themselves from burnout? Because by 7 days a week, day after day, you're looking after the person who's not responding to you, who's giving you a hard time. You can get burnt out. You can get angry. You may get even hit out to a person sometime. And then you feel very guilty about it. But that's the reality. And you have to accept that and try to understand what's happening to yourself and to them. And so then you become stressful. And so there has to be stress management. So some caregivers have to provide 24-hour care, 7 days a week, day and night, assisting with all activities of daily living. Now, this what I'm saying, I'm giving you more examples of people with dementia, but this can also happen with people with other types of diseases where you have to give 24-hour cares. That can be a stroke patient. It can be an accident patient. It can be anything. Such round-the-clock care is needed when the person cannot be left alone. You cannot leave the person. You have to have somebody come in whilst you're gone for shopping. Otherwise, you become a prisoner in your own house. 32% provide care like this for about 5 years, because this late stage of the disease can last for that long. And 39% provide for about 1 to 4 years. It's a long time. Caregivers range in age. The 14% are under 35, 26% about 35 to 49, 46% between 50 to 64, and 13% age 65 and over. So the older you are, this more difficult. And the average age is about 51 for a caregiver. And that's the sandwich generation. They have to look after their own children or their grandchildren, and they have to look after their parents. And most people in the, and this is a strange, it's a sad story. Most people in their 70s are looking after people in their 90s, whether the spouse or the child. What do the caregivers do? Shopping, preparing meals, providing transportation, taking them for appointments, helping them with the medications, either long distance on the phone or physically, follow treatment recommendations, managing finances and legal affairs. Excuse me. Supervision to avoid unsafe activities as wandering and getting lost, making sure the doors are closed, they cannot get out, providing them bathing, dressing, feeding, helping the person use the toilet, or managing incontinence with the diapers, changing the diapers, making arrangements for medical care and paid in home assistance. Sometimes you have to go out, you ask for a paid care, it doesn't come. What are you going to do? You have to make alternate arrangements, to have an alternate plan. And you have to manage behavioral symptoms. All that is to be taken care of. So when you're given all these pressures of caregiving, what happens to you? The caregivers experience sometimes depression. Sometimes they want to commit suicide. They become physically ill because of the stress levels. And there is premature death higher than in the general population for people who are caregivers. Either sometimes it happens that immediately after the person you're looking after dies, there is a higher rate of premature death. And most problems are related to stress. 40% of caregivers suffer from some sort of stress. The high levels of stress create more problems. And because of stress, our immune function, which really controls your diseases and keeps your body in control, is reduced. Just like this happening in COVID, your immune functions are lowered down. There's an increased risk of hypertension, because the more stressed you are, your blood pressure rises, even without looking after a dementia patient. Any stress in the community, any stress for you raises your blood pressure. Heart disease is another problem. There's a strain in marriage because the husband will feel that he's being neglected. You're looking too much after your family. So that's a problem there. And as just 1 second, let me close this. There's a high level of our relationship is usually elastic. When you have a good relationship with the person you are looking after, you can manage, you can take all sorts of problems. But when the relationship was not good to start with, that safety net becomes like a sieve. It's not something where you can go on indefinitely. And the first things to go is your peace of mind. When you're very anxious, when you're stressful, you don't have a peace of mind. So what is stress? Stress is a biological reaction to physical or environmental danger. The stress is everywhere. But how you react, there can be acute stress or there can be chronic stress. Acute stress is good because it's temporarily, you react to that, you solve that, and it's gone. But chronic stress is not good because it accelerates aging. And looking after an elderly person, looking after somebody with dementia, day in and day out, 7 days a week, is not good. It accelerates aging, and that is chronic stress. And stress can be expressed as physical. You can have headaches, be fatigued, loss of appetite, you don't sleep well. That can be stress, can be mental. Your memory doesn't function well. There's lack of concentration, there's inability to make decisions. It can be emotional. You become tense, nervous, frustrated, depressed, anxious, and behavioral. Things which you never did before. People start smoking, people start drinking, people start overeating. There's nail biting, they become swearing. They become all sorts of behavior problems, which is there in the patient. You start reflecting yourself. So these are this stress is expressed physically, is expressed mentally, emotionally, and behaviorally. And that is, people who are giving care should be responsible or cognizant of that, because that affects your caregiving ability. So what are the 10 stages, signs of caregiving stress? Denial. You said, no, nothing is happening to me. I'm fine. I can manage everything. Or you can have anger. You feel really angry at that person. Why am I being left with looking after this? You can be angry with your siblings, or can be angry with somebody else. That why is nobody else helping me? You try to withdraw socially. You don't want to mix with friends. You don't want to, because it's too embarrassing. You don't want to go anywhere. You become anxious as to what's going to happen. Who's going to look after me when I become, oh, whatever, how am I going to manage all this? You become depressed. There's exhaustion. You get tired. I mean, if you don't sleep well, you get sleeplessness, you don't sleep well, you have no time for yourself, you become exhausted mentally and physically. And then you become emotional lability. You become angry, you become annoyed. And as I said, sometimes it happens that you may say, oh, give a little pat to the person you're looking after, saying that, why are you doing that to me? You know, don't you see that I'm so exhausted? Why are you waking up so many times? But that person doesn't know what they're doing. But you feel, and then you feel guilty about doing this. Then there's a lack of concentration. You can't concentrate because your memory is not there very well. And then you start beginning to have health problems yourself. And you tend to neglect it because you don't have time to go to the doctor yourself. Because it's a whole rigmarole. So you have to plan. And so what are the 10 ways to reduce your own stress and to be able to manage this? As a caregiver, you need to look after yourself. That is the most important thing. To be able to look after the person you love. You won't be able to look after the person you love unless you look after yourself. Learn about the disease, as I said. Be realistic about the disease. What you can expect the person to do and what you cannot expect them. You don't expect the person to behave as you would like them to behave because it's not possible. That's a part of the disease. And then be realistic about yourself. Be realistic as to what you can do and what you cannot do. You cannot become a hero or heroine and say that, oh, I'll look after the person. I promise the person I'll keep them to the end. I will never place them. But if you think that you're physically not possible to do that, you have to try to look for help outside. You have to try to see if you can get 24-hour care in a placement. You have to accept your limitations yourself. Accept your own feelings and share your feelings with others. If you have a friend, or if you have a close sibling, or if you have somebody with whom you can say, oh, I'm feeling so tired today, I really can't go on, I don't know how, what am I going to manage? And just don't be too heroic to say, oh, everything is perfect, I'm looking after them very well. Positive, look for humor, take care of yourself, get help, and plan for the future. So how do you cope with stress? Change the way you look at things, take nutritional health seriously, exercise, one of the best, most efficient ways to reduce stress, practice relaxation and meditation, get more sleep, buy yourself some relief, hire help, book a massage if you can afford to, and if you can have the time, pace yourself. Don't try to do everything yourself. Don't overextend. Avoid being overextending yourself, and build a support system. Have some backup plans for yourself. And the first step in reducing stress is to take back control of your life. Okay? So getting old is natural. We're all going to get old, but feeling old is optional. You don't have to feel old. You have to be optimistic and be glad that you're living to this age, because everybody doesn't have a chance to live up to 90. I have Carrie here on our plan, our group here today, who's 90, and she's wonderful, and she's here. And so she doesn't feel old, and feeling old is optional, as I said. So thank you very much for giving me this chance and opportunity to share some of my knowledge and understanding with you. And I hope that was useful.